everyone on behalf of Transplant Families and the Action Learning Network. My name is Joseph Hillenberg, and I'm father to a 13-year-old pediatric heart transplant recipient. Transplant Families is a parent-led organization which provides a number of key benefits to the pediatric transplantation community. This includes support for transplant recipient families, educational resources and workshops such as this one, community outreach events, networking opportunities for families, and patient-centered research, including a joint effort with Action Learning Network and other provider learning networks to foster advocacy and leadership in young adult recipients. Please check out our other resources on social media, including our extensive YouTube library of almost 100 educational videos oriented towards people like you. For this presentation, we are proud to partner with Action Learning Network, which works to improve outcomes for children who are in heart failure, on the transplant waiting list, or on a ventricular assist device. I would like to call attention to an excellent pamphlet that Action has prepared on today's topic, covering the benefits of SGLT2 inhibitors. You can find this and more at myactioneducation.org and in the resources section of this webinar. I would like to introduce our presenters, all of whom have conducted original research in this area. Dr. Mary Chandran is a clinical pharmacist practitioner at the University of North Carolina Medical Center. She specializes in kidney and liver transplantation, working with adults and pediatrics. She has a strong interest in assisting young adults as they transition to adult care. Dr. Joseph Spinner is an assistant professor of pediatrics at Baylor College of Medicine and the associate medical director of cardiac transplantation at Texas Children's Hospital. He is an active member of Action, the International Society of Heart and Lung Transplantation, and Pediatric Heart Transplant Society. Dr. Alex Kula is a pediatric nephrologist at Ann and Robert H. Lurie Children's Hospital of Chicago. In addition to his clinical work, he has conducted a great deal of work on the intersection between chronic kidney disease and cardiovascular issues in children. He is currently holding SGLT2 inhibitor studies, so if you like what you hear, please be sure to connect with him. I will now turn the microphone over to Dr. Chandran.
Thank you for that introduction. My name is Mary Chandran, and I'm very excited to be here with you all today to discuss the role of SGLT2 inhibitors in transplantation and how these medications may be beneficial for transplant recipients, including children, adolescents, young adults, and beyond. Today, we have a great group to really give a broad overview of how these medications can fit into patient care. I'm going to really focus in on what these medications are, put some background for you in terms of what they're being used for today, what we think future potential uses are, and some good knowledge about having these medications with regards to safety, side effects, and so forth. And then we'll get to dive a bit more into the heart benefits and the kidney benefits associated with these medications to really give the full picture of what potential we all feel that there is with using them in our medical treatment. So in terms of where we'll start, I just really want you all to understand what SGLT2 inhibitors are. I want you to be familiar with that terminology when you hear those words thrown around, what medications are being talked about. And then, as I mentioned, we're going to look at the heart perspective with regards to SGLT2 inhibitors, and then the kidney perspective, and wrap that up with some questions and answers to really help clear up any concerns, areas of confusion, and so forth as we complete the presentation. So let's start with the background. What are SGLT2 inhibitors? It's a little bit of alphabet soup in terms of a drug name, but it is an abbreviation for a drug class known as the sodium glucose cotransporter 2 inhibitors. And this is a group of medications. They were first developed for the indication of diabetes, and so they were used to lower blood glucose and treat type 2 diabetes. They are oral medications and generally given once daily. But what we have learned in more recent years is that there are lots of other benefits with these medications. Most importantly, and most relevant to this topic, is that there seems to be a lot of benefit with regards to heart outcomes as well as kidney outcomes. The name of the medications I have here on the bottom, I have both the brand name and the generic name to help you familiarize yourself with what these are. But the available agents include canagliflozin or Invokana, dapagliflozin, Farxiga, empagliflozin, Jardiance, and then the newer agent, sotagliflozin and PEFA. And so you may recognize some of these drug names from commercials or hearing these in your clinic visits or among other patients or families that you are in conversations with. So how do these medications work? Their primary source of action is within the kidney. The intention is that they block receptors that help the body reabsorb glucose and sodium from the bloodstream. So if these things are not being reabsorbed, they're being excreted. And being able to remove those excess things, such as glucose and sodium from the blood, have the benefits that we see, particularly with the initial indication for diabetes, because blood sugars can be reduced if they're being excreted through the kidneys as opposed to being reabsorbed into the bloodstream. Blood pressure can be lowered, particularly if you think about the loss of sodium through kidney sources. There's some potential for weight loss, and then many, many more things that we're going to talk more about today. For those of you that are visual, including myself in the room, if that was a lot of words, I like to put a picture to that. So what I have here on the screen is a picture of the glomerulus and the tubule of the kidney. So you can see that the particles in green are meant to represent glucose, and those glucose molecules within the bloodstream would pass into the kidney, into the glomerulus to be filtered by the kidney. Typically, that excess glucose can be reabsorbed by this SGLT2 receptor, in which case the glucose would then leave the kidney and go back into the blood. That would be the opposite of what we want to happen in someone who has elevated blood glucose levels or blood sugar levels. So these medications can actually block this receptor, allow that glucose to stay within the tubule of the kidney, which would eventually lead to those molecules going into the urine that's excreted from the body. So if that excess glucose or excess blood sugar is leaving into the urine, it gets out, blood glucose levels go down, and that's where we see that primary benefit of these medications. And this is really the basics of how these medications work, but it only begins to touch on the surface of what a lot of the other benefits can be seen in blocking those inhibitors, removing that excess blood sugar, removing excess sodium, and so forth. And a lot of the interest that we have now for using these medications beyond just that diabetes indication. And so that leads into this part of the focus of the impact of these medications. So I want to start at the top of the screen. And again, really these medications were meant to be used for blood sugar control. And you'll see that they do in fact reduce hemoglobin A1C, or the marker of blood glucose concentrations over a 90-day period. We use A1C typically to diagnose diabetes, so which is generally the gold standard with regards to diabetes outcomes. And what we can see when using these medications, in adults, we see an A1C reduction on the scale of 0.5 to 0.8%. When looking at that data in children and adolescents, we see similar, if not higher, reductions in A1C, with reported numbers on the scale of 0.7 to 0.9%. And specifically, this is looking at individuals who do have a diagnosis of type 2 diabetes. But now let's step away from the focus on blood sugar and look at some of these other outcomes that really do seem to be of interest and that we want to focus on today. So specifically with regards to cardiovascular outcomes, many of the studies with these drugs look at what we call MACE, or a major adverse cardiac event. And that's sort of this global term or composite endpoint that encompasses many types of cardiovascular events. There really isn't much in regards to pediatric data, but what we do know in adults is that the patients who use SGLT2 inhibitors with or without cardiovascular disease do have about a 9% reduction in risk for a major cardiac event. And that is independent, it appears to be, from other disease states. So it's a sort of a class effect, if you will, in terms of cardiovascular protection. Moving into a different outcome or a different organ that we're focused on today would be that of kidney outcomes. And so when we think about kidney outcomes in the data that has been looked at with these agents, it's really looking at kidney function with regards to progression of disease or acute kidney injury, and so decline in kidney function. Again, not much data available to date with pediatrics, but we do have adult data to give us some indication of how these medications may work. And what we have found to date is that in adults, there's about a 30% reduction in disease progression. And so patients can maintain EGFR or levels of proteinuria. We see a decrease in the incidence of acute kidney injuries and a reduction in the incidence of kidney failure. So all of these things are very promising, particularly in a patient population such as transplant recipients, in which we want to both reduce cardiovascular outcomes and negative events, and we're also trying to preserve kidney outcomes, either be it because you have a kidney transplant or you have a different type of transplant and we want to preserve that kidney function in the context of using many of the medications we use in transplant that we know to be perhaps toxic to the kidneys. So a lot of exciting information here that is on the forefront in trying to apply this to many populations, including transplant, and be expanding that beyond our adult patients. So that's really the focus of our talk today. Where can SGLT2 inhibitors fit into our portfolio of transplant management and medications that are focused on the long-term benefits and good outcomes for our patients? And so there's a lot of overlap in transplantation between the kidney function, heart function, and outcomes, as well as pancreas in terms of diabetes, post-transplant diabetes, hyperglycemia, and other cardiometabolic outcomes. And so this Venn diagram, if you will, has a lot of overlap. And so the potential for improving all of these outcome areas with the medications such as SGLT2 inhibitors is very exciting and very enticing to us and to yourselves in terms of getting a strong benefit for our transplant recipients. So to put this in the context of transplant, so we're all very familiar that transplantation requires the use of chronic immunosuppression. And while those medications are fantastic at preventing rejection and giving us long-term graft outcomes, we know without a doubt that those medications come with their own host of concerns and side effects. Many of these you are all well versed in and well familiar with. We can see electrolyte abnormalities such as low magnesium levels, high potassium levels. We can absolutely see elevations in blood pressure where there's the need for antihypertensive therapy. We can absolutely see weight gain and weight fluctuations, be it with fluid shifts and fluid gains, and actually just adipose tissue or metabolic changes in the setting of our medications. Additionally, we can see elevations in blood glucose where we may have prediabetes or a new diagnosis of diabetes after transplant. And then, of course, we know long-term, many of these cardiovascular metabolic complications can result in cardiovascular risk in the long term and in the big picture. So knowing that all of these things are common complications of transplant immunosuppression, it is pretty promising that SGLT2 inhibitors essentially have a response or a solution for each of those areas or pain points that we see after transplant. And so just starting at the top and working our way down, there is evidence to show that SGLT2 inhibitors can actually improve some electrolyte abnormalities. Specifically, magnesium levels can be increased, which may help to reduce the need for supplementation. We can see some uric acid reductions that may be beneficial for patients who experience gout. We can see some reductions in blood pressure, albeit small, but still some notable blood pressure changes for patients that start these medications. There is potential for some weight loss and perhaps some improved fat utilization, specifically if patients have good blood glucose control. leading into that, we can absolutely see good glucose control. So a patient who may be pre-diabetes, and this is helping them to prevent that diagnosis, or a patient who has a diagnosis for diabetes, but may be able to use these medications and only have to be on oral therapies instead of injectables to control their blood sugar. And then ultimately, this sort of all adding into that potential for reducing those major adverse cardiovascular events for our patients in the long term, so that we have good cardiovascular outcomes in these 5, 10, 15 plus years following transplantation. So all of that is very exciting. There's a lot of good things that we see with these medications and a lot of potential for use. But I want to acknowledge that these medications don't come without side effects, and there are some considerations to talk about when selecting these medications for patients. The most notable being that these medications have been associated with an increased risk of urinary tract infections and genitourinary infections. And while the data does suggest, well, in terms of retrospective data, small cohort studies, that the risk is no greater in transplant recipients. So it's still there, but individuals on immunosuppression don't appear to be at significantly higher risk for getting these infections. But I will put the caveat to that being that patients are being selected with the focus on the risk for infection. What that means is, to date, at least in my practice, I would not want to start one of these medications in someone who has had many urinary tract infections to date, because I'm already worried about their risk. So I would be hesitant in that scenario. But if I have a patient who has not had many urinary tract infections and I'm not particularly concerned about their risk, I would feel comfortable moving forward with introducing this medication, knowing that I'm going to be very focused on any signs and symptoms of a urinary tract infection and wanting to be quick to jump on any treatment for those or testing for those if one should arise. The other thing is that these medications do increase urinary output. With that extra glucose that's leaving the kidney, with that extra sodium that's leaving the kidney, there's a lot of volume and fluid that follow. And so if someone is not doing a good job of drinking and staying hydrated, we will see patients becoming dehydrated with these medications as they lose more volume and more fluid than they are used to with their urine output. So it's very important that patients are drinking very well, hydrating well if they're going to be on these medications for the safety of their kidney function and their fluid status. And then lastly, it is very rare, but there is concern for patients developing diabetic ketoacidosis with the use of SGLT2 inhibitors. And this is specifically in patients who have a diagnosis of diabetes. And the main concern is that if a patient is going through a stressful event, so for example, a surgery, or they are NPO and not eating, or they're having a stomach illness where they're having lots of vomiting and diarrhea and they're not able to eat and drink appropriately, we can see abnormalities in their labs in which a patient may have increased ketone production and can have some confusion and some scary events there. I will say it's not something I've encountered often with my use of these medications, but it's always something that I tell my patients about so that they know they may need to hold medication if they were in one of those scenarios. So all of this to say, there are risks to consider. These risks should be discussed and evaluated before starting one of these medications, but there is a lot of exciting potential with introducing these medications into our repertoire of medications that we use after transplantation. And with that, I'm going to hand it over to Dr. Joseph Spinner from Texas Children's, who is going to now focus in on the heart component or the heart aspect of using these medications after transplantation.
Hello, everyone. My name is Dr. Joseph Spinner. I'm a pediatric cardiologist, and I specialize in heart failure and heart transplantation at Texas Children's Hospital in Houston, Texas. Thank you so much, Mary, for that excellent overview of SGLT2 inhibitors. I am now very excited to bring us to the next part of the discussion, which is discussing how these medications can help the heart. Again, just to reemphasize what this medication is, an SGLT2 inhibitor is a medication that blocks a specific receptor or channel in the kidney that is involved with how your kidneys deal with blood sugar. And they have a funny sounding name. All of these medications will end with the letters or the word gliflozin. So there's dapagliflozin and empagliflozin. Those are the generic names of these medications. And even though they are medicines that act on something in the kidney and deal with something having to do with your blood sugar, these are actually heart medications. So you may have actually heard of these medications without realizing it. So I'm going to play this very annoying commercial, which is for one of these SGLT2 inhibitors.
I have type 2 diabetes, but I manage it well. It's a little pill with a big story to tell. I take once daily Jardiance. At each day start, as time went on, it was easy to see. I'm lowering my A1C.
Jardiance works 24/7 in your body to flush out some sugar. And for adults with type 2 diabetes and known heart disease, Jardiance can lower the risk of cardiovascular death too. Jardiance may cause serious side effects.
So they kind of buried the punchline there. At the very bottom, they put heart disease, and they very briefly mention a heart disease, but it is not a diabetes medicine. It is a heart medicine, and I hope that this won't be stuck in your head now the rest of the day, but you've probably seen that commercial. So if you ask me, the cardiologist, how I would design the perfect heart medication, I would want it to improve systolic heart failure outcomes. That means I would want it to help your heart squeeze better. I would want it to improve diastolic heart failure outcomes. That means I want your heart to relax better. I would want it to be given only once per day. Limited titration means we don't have to go up, multiple different doses and keep increasing the dose and watching your heart rate and blood pressure, and not have any effect on your heart rate and blood pressure. So I don't want it to make your heart rate get too fast or too low, or your blood pressure get too low. And I wouldn't want it to be affected by kidney function, either that it causes kidney problems or that kidney problems may prevent you from needing to be on the medicine. So this is how I would design the perfect drug for improving hearts. I want to stress that this is not just a diabetes medicine, even though that's how it was initially designed or studied or marketed. It does a lot of other things that help your body. They decrease oxidative stress. That's good for your body. They restore mitochondrial health. That's the energy center of each of our cells. So these medicines help your mitochondria, your energy producers. Importantly, they lower inflammation. That is very important. And it can actually help improve your iron levels as well. And so now we don't have time to get into these studies and going over all these scientific data, but there have now been a number of very famous trials that have been published in the New England Journal of Medicine and the really, really good cardiology journals, really well designed heart studies in thousands of adults. And they showed us that independent of diabetes, meaning in adults who don't have diabetes, these medications helped the heart squeeze better and keep adults out of the hospital for heart failure. Now, you could say, well, there's already other medicines that do that. Some of you may have been on some of these other medicines or have heard about some of these other medicines that help the heart squeeze. So, this may not sound so impressive that this is yet another medicine that helps the heart squeeze. However, what is really important and that I want to stress is that there have now been newer and now very well regarded trials in adults, again published in the New England Journals of Medicine and other very important and prominent studies, is that these medicines actually help the heart relax. And this is very important in transplanted hearts. And so this is really the game changer here, is that while all the other medicines that have been studied and worked on help the heart squeeze, they didn't really help the heart relax. And this is what gets me so excited for children who've had heart transplants, is because typically the heart is still squeezing quite well. The problem that we start to see over time is the heart may not relax well or have troubles relaxing. And so this is why this medication is potentially a very important addition to our toolkit. If I had to summarize all of the different studies of of how this medication helps the heart in adults. There have now been over 70,000 patients in over 10 trials who received these medications, and it dramatically lowered the combined risk of death due to heart failure or hospitalizations due to heart failure. Importantly, the medicines don't only help when the heart doesn't squeeze well, but it also helps when the heart has a normal squeeze. That's when the ejection fraction is normal, but the heart doesn't relax well. This is why I'm so excited about this medicine. These medications improve quality of life, they make the BNP lower, and they actually help the kidney function, and we'll hear more about that later. These medicines are safe and very well tolerated. It's important for me to say now, and it's important for any doctor to talk about with you, is that any medicine has the potential for side effects. And so there is a known, very small, slight increased risk of having a urinary tract infection or potentially a genital infection, and that's something that I definitely need to mention, and that your doctors, if they prescribe this medicine, need to go over with you. The other thing, and again we'll hear more about this, is that there may be an initial decrease in one of the labs that monitors your kidney function, but it's actually better for the kidneys, and I'll let the kidney doctor after me go more into detail, but this is actually potentially protective for your kidneys as well. Well, what about in kids? Well, we're just starting to use these in kids now over the last 3 to 5 years, and we're starting to learn more. The Children's Hospital in Seattle is one of the first hospitals to really start getting experience with it. And now these numbers are higher, but this is what they've published in the medical literature. They treated 38 pediatric patients with heart failure whose average age was about 12 years old. These are mostly children before transplant, so these are children who had dilated cardiomyopathy with very low heart function, and what they showed is that the BNP decreased, the heart function was better, and there was a small risk of having a urinary tract infection. So almost 1 out of 10, a little bit more than that, children ended up having a urinary tract infection on the medicine, but it was easily treated, and importantly, there were no low blood sugars, even though this was marketed initially as a diabetes medicine. In Michigan, they also were an early adopter of this medication. They gave this medication to a number of children who had a Fontan, so they had a form of congenital heart disease, had had a number of surgeries, and prior to getting a heart transplant, when they were having heart failure related to their congenital heart disease, this is when they got the medicine, and that they showed that it was generally very safe. It improved the heart failure labs, the BNP and NT-proBNP. There was one patient who, when they received this medication, was actually already very, very, very sick. And this patient did have a decrease in the labs that monitor the kidney function. But again, overall, this is actually a medicine that helps your kidneys, and we'll hear more about that in just a few moments. What about more broadly than just 10 patients here, 10 patients there? We have now studied this medication across the ACTION network. So we've now had this medication. Actually, over 300 children have now received the medicine, but we recently just published and reviewed our experience of the first 250 patients who received the medication. A lot of these children had heart failure and were needing a heart transplant, so this is before transplant, but it's very exciting, and we've been early adopters of this at Texas Children's. We've treated a number of children with heart transplants now with the medicine, but this study included over 30 patients who actually were heart transplant patients. So this is now, for the first time, I'm mentioning children who've had heart transplants who received this medicine. So not just adults and not children with heart failure, but these are children who got heart transplants who got the medicine. What we saw is that a number of these children were able to stop their diuretics or their Lasix. We were able to see that their BNP was lower, and all the other labs did not change. So it did not affect their electrolytes. We did see a few children, 12 of the 254, where the labs that monitor the kidneys, the one lab value changed a little bit, but again, this is good for the kidneys, and 10 children out of 250. So there definitely were children who had UTIs. We have seen them in the transplant patients, and so if you start this medicine, we do have to keep an eye out for UTIs, but they were all very minor UTIs that were able to be treated. One small child did have a genital infection, and that has to be watched over closely. And then 2 patients had what's called ketosis, which is something that can happen if you don't hold the medicine before having a planned surgery or operation. And so if you do start the medicine, we do ask that you hold the medicine a few days before any planned procedures, because in those kids, it can sometimes affect their insulin and blood sugar levels. I'm going to get back to the slide, which is how would I design the perfect medicine. And the reason why I have this up is because this one medicine does all of these things. It does literally everything I've wanted in a heart medicine. It's given once per day. It helps the heart squeeze. It helps the heart relax. So it's really just a wonderful medicine. And that's why I'm very excited about it. In summary, these medicines are now being used across over 30 pediatric heart failure and transplant programs. We are giving these medicines to heart transplant children now. This medication is very well tolerated in children. It appears to lower the BNP and help the heart squeeze and relax better. So that's really important. Side effects are rare, but they are definitely possible. And again, I've said this now a few times. I want to remind everyone there is a small risk for having a urinary tract infection. And so if your child complains of burning or pain when they pee on the medicine, we do need to check their urine for a urinary tract infection. And then you have to stop the medicine 2 to 3 days before procedures. So if you're going for a planned surgery, if you're going for a heart cath biopsy, that's part of your routine care, you do need to stop the medicine a few days before the procedure, or at least let the anesthesiologist and the cardiologist remind them that they're on the medicine if they're on it. Lastly, before I hand this over to our kidney specialist, I want to mention that at Action we put together a number of very nice handouts on a lot of the different medicines that we prescribe, but we really put a lot of effort into making some really good information for this new class of medicine, the SGLT2 inhibitors. So I did want to show you this here if you want to take a picture or screenshot of that. And with that, thank you very much for your attention, and I look forward to hearing from our kidney specialist and answering any questions that you have. Thank you.
Thanks so much, Joey. I'm so grateful for the opportunity to be here with you all today. My name is Alex Kula. I'm a pediatric nephrologist at Lurie Children's Hospital in Chicago, and I have a particular interest in the interaction between the heart and kidney and in health and disease. And I'm excited to talk about the kidney perspective of using these wonderful medications. And I might be slightly biased, but I think this is the most important perspective because these medicines primarily work on the kidneys. So let's get right into it. So one thing that I think I always try to reinforce with my patients is that kidney health and heart health, they're inseparable. So it doesn't matter where the problem starts, whether with the kidney or with the heart, the other organ will eventually be involved. And if they don't work together, it's not going to have a good outcome. So it doesn't matter who falls first. If one falls, then we have to think about the other and think about how that affects the big picture. So a lot of this presentation has highlighted the tangle of mechanisms that connect kidney and heart disease. And it really is a tangle. Take a look at this figure. There's lots of arrows. There's arrows going both ways. There's arrows intersecting other pathways. It really can be difficult to unwind sometimes. And it is difficult to treat when the heart and kidney are ill because there's no single pathway that is responsible for the majority of the damage. And every patient may have a unique combination of disease mechanisms or disease pathways causing their issues. Kidney disease can compromise heart health, even in young patients. In my research, we've identified that many young adults in their 20s, 30s, 40s who have kidney disease alone will go on to develop heart disease, primarily heart failure. As a next step, we're now researching how can we better identify subclinical heart failure or cardiovascular dysfunction in young people who have kidney disease to help prevent the development of more serious heart problems later in life. Now, all of this to say is why kidney health is such a priority in our patients who have existing heart disease and why I'm so passionate about treating this population. I also think this highlights why SGLT2 inhibitors could play such an important role in the care for patients at risk or with concomitant heart and kidney disease. So look here. These are a few of the many mechanisms that connect kidney disease with cardiovascular disease. Often as a nephrologist, we'll treat each mechanism with its own medication or own treatment strategy. But something amazing that we noticed when we started doing studies of SGLT2 inhibitors was this one medication had a broad positive effect across multiple mechanisms. So if you look at any one mechanism that connects the kidney to the heart in disease, you'll see that often SGLT2 inhibitors have a positive effect on that mechanism or reduce the risk associated with them. So just like Joey had said earlier in the presentation, why they're such an important part of our treatment for these patients. And I think it's kind of exciting in some ways because it's changed how we understand the complex web here between heart and kidney disease. And something that I've gotten the impression of, and I think many others in the field have too, is that what SGLT2 inhibitors are teaching us is that there's, one of the most central mechanisms that connect the kidney and the heart is this metabolic communication. So that's why this diabetes drug does so much to improve both heart and kidney outcomes. One thing worth noting is that both the heart and the kidney, these two organs are some of the most energy-hungry organs in our body. The metabolism that goes on with them is at much higher rates than a lot of other parts of the body. So it makes sense that they'd be sensitive to things that affect that metabolism or have adverse effects related to abnormal metabolism. And this is not like metabolism that what you eat, your diet, or how many calories, but within the cell itself and the pathways that are utilized. And so now that we have this kind of exciting background and I think convincing reason why these medicines should be used more in our patients with cardiorenal disease, here are just a few very specific considerations I have as a nephrologist. So one thing that can make a lot of people anxious when starting these medications is after you start it, it's very likely that they'll make your kidney function appear worse. And so creatinine or cystatin C, those are two blood tests we use to estimate kidney function. You'll see that those increase, which suggests GFR, the filtration rate of the kidney, has decreased or gone down, which is bad. And often people are like, why am I taking this medicine to protect my kidney if it's going to make it worse? But the important thing to remember is this acute change in that first 1 to 4 weeks is completely reversible and is not the result of any structural changes in the kidney itself. And so while you'll have that, so if you compare a group like you see in this figure below, the red dotted line being those who don't start SGLT2 inhibitors, the blue being who do, you can see in that kind of like zoomed in section that at first the blue group drops a lot more than the red group. But over time, and we think usually 1 year is the cutoff, those two lines cross. And then you can see as you go out into the future, if the y-axis or the up and down is your filtration rate, where higher is better, you can see that the rate that goes down in patients on the medicine is much, much gentler than those who aren't taking it. And we think it can have a substantial change, especially the longer patients take it. So for our young patients, we think this could be wonderful for their kidneys. Some of the contraindications in the patients we have to be very careful and possibly avoid their use in right now from a kidney perspective is one, those who have type 1 diabetes, I think we talked about earlier. One place that we're becoming more comfortable is those who have obstructive uropathy or history of recurrent urinary tract infections. So if there's issues with how urine drains from the kidneys to the bladder outside the body, sometimes you need to be a little more cautious. And really, it's just those who have severe disease. So some individuals are born where they need to use a catheter to urinate, and those patients have a high risk, and so you probably wouldn't want to use it. But we're becoming more comfortable, and many nephrologists are okay using it in them, like me. Also, low blood pressure, because they do slightly lower your blood pressure. Although I've yet to encounter a patient who had a blood pressure low enough where I was like, we shouldn't be using this. I think if you're out of the hospital and you're walking into clinic, you have a fine blood. So what this whole presentation has demonstrated, given the number of slides that have both a kidney and a heart on the same slide, is that we need a lot more collaboration between nephrologists who treat kidney disease and cardiologists who treat heart disease. And when there is that collaboration, you see that good things can happen. So here's an example from when I was on service a few weeks back. There's a 17-year-old who had severe heart failure. So he was born with structural heart disease. He had had many surgeries. And as a result of that severe heart disease, it had caused a lot of damage to his kidneys. So over the years, he's had a steady decline in his kidney function to now the point where we say he has ESKD, or end-stage kidney disease, which means kidney failure. Those are patients who need dialysis or a transplant. And he was on dialysis. We were doing peritoneal dialysis for him. Now, despite doing dialysis and having failure, he still had a little kidney function, that 5 to 7. So the number above 90 is usual. Below 15 is when we kind of consider that you're in failure. So you can see he has very little kidney function. Now, as part of his clinical course, he had had worsening of diastolic dysfunction in his heart over the last week or two, and he already maximized a lot of the cardiac medications. And when we were all discussing, it didn't seem like there was too much else we could try. So then we wondered, this is a patient who might benefit from an SGLT2 inhibitor. Now, the one downside is these medicines work primarily on the kidney. And so would he still benefit in the same way? And we had to consider that. What would be the benefits? What would be the downsides? And I think after a long conversation, what we recognized is that the worst that could happen for this young man is that the medicine wouldn't work, but there wouldn't be a negative to trying. And so it's great that we had this conversation, because then we could try, and we also could be thoughtful about our data collection afterwards. And what we saw in the few days after starting this medicine is, one, that there was sugar in his urine studies, which shows us there was enough kidneys still awake for the medicine to bind to. We saw that there was a decrease in the amount of protein in his urine, which is a positive sign for kidney health. And we also know that lowering the amount of protein in the urine signifies those who have less of a risk of heart damage related to their kidney disease. He also had a slight increase in his urine output, so that made keeping his volume status and not having to do dialysis quite as aggressively. And then importantly, it didn't make things worse. He still had that kidney function. So this was a big success, and this patient ended up doing very well. He went on to receive both a simultaneous heart and kidney transplant, and is now back home and living his best life. So it's just a really happy example of how this collaboration can lead to new opportunities and new medicines like SGLT2 inhibitors for our patients. Thank you so much for the chance to talk with you today, and now I'm going to hand it back to our host, Joseph.
Hello, everybody. Thank you for staying with us for this live Q&A. Unfortunately, one of our presenters, her internet access died during the presentation, so that's Dr. Mary Chandran. She will not be able to join us. So if you have any questions for the group, if you would like to throw them in Q&A, I'll get us started with a couple. One is for, and I hope that both of you, with Dr. Kula and Dr. Spinner being that your perspectives are from different organs. I was hoping to ask this to Mary, but hopefully you two could field this question. Can liver recipient children benefit from SGLT2 inhibitors? And I'm just going to ask you to try your best with that question, knowing that, again, Dr. Chandran, who's more of a general expert, is not here.
Well,
Sure. Go ahead, Alex.
I was just going to say that I had a patient in my clinic who actually is a liver transplant recipient who we started on this medicine due to metabolic dysfunction. This patient also had some mild kidney disease as a result of going through the liver transplant. So we've started it and it's been successful. I think the liver is actually an important mediator in that metabolic communication between the kidney and the heart. In fact, we have a clinical trial here for individuals with fatty liver adolescents using SGLT2 inhibitors to improve their outcomes. And as a secondary outcome, we'll look at kidney function as well. So I think there is a real use. That's a real use case.
I would just add to what Dr. Kula was mentioning. I loved his slides that he shared and this interaction between the organs.
And if you watch any medical dramas or shows or see memes, it's not uncommon to show the cardiologist, the heart doctor, the nephrologist, the kidney doctor kind of butting heads on going one way or the other. But in reality, the organs are intertwined, and I would throw in the liver as the triangle in that. And so I would say it's not uncommon that someone who's had liver disease may also have some kidney or heart dysfunction. And so in that regard, it is possible, as he mentioned, that there's some benefit. I haven't personally prescribed the medicine to someone who only specifically has had a liver transplant and doesn't have heart or kidney dysfunction. But if there is, again, the crosstalk between all the organs and some heart dysfunction in the context of the liver disease, I would feel very comfortable prescribing this medicine to that child.
Thank you. So we had one question from the audience. They asked essentially how SGLT2 inhibitors might compare to GLP-1 medication.
They work in different ways, and that's been all the rage in cardiology are these new medicines. And I have to admit, it gets a little confusing. There's the GLP-1, there's the SGLT2. Do they do the same thing? They are different medicines. They work in different ways. I think why we're so enthusiastic and excited about it is that both of these classes of medications seem to work on specific pathways that involve your body's metabolism and inflammation that are very positive. I have patients that are children that are on both medicines. They may be on both medicines because the endocrinologist, the diabetes doctor, may have prescribed one or the other. And I have other patients who are heart dysfunction patients that we prescribe them both to help their heart. I will just point out, we specifically think about the GLP-1s, that's Ozempic, Wegovy, there's a Zepbound, there's a number of them. We specifically think about those medicines in adolescents or young adults who have obesity and obesity-related problems. If you do not have obesity, if you have a normal body mass index, it would be almost impossible to get that class of drugs prescribed, the GLP-1s. You do not have to have obesity or metabolic syndrome to be prescribed or benefit from the SGLT2 inhibitor. But you can be on both medicines simultaneously, from my perspective.
Dr. Kula, do you want to add to that, or I have other questions too? So.
Yeah, I think I share all of Dr. Spinner's opinions on it. The one caveat I'd add is here in Illinois, I've tried about 10 times to get it prescribed for patients, and I've been unsuccessful. It's so every state has a different policy, and I talked to my colleagues in different states, and they're putting all their patients on it. And whereas I have tried repeatedly different techniques, I've talked to lots of people at insurance companies, and they draw the line for these medicines, even though their FDA indication is there, and even though they would help our patients greatly. So just check with your provider.
Okay, so another question would be...
Joseph, if you don't mind, I want to add a quick comment.
Sure. Go ahead. Sorry.
As these drugs have become so popular for a lot of reasons, it's not uncommon that someone may seek to try to obtain this medication through a compounding pharmacy. It's because it's much less expensive that way. I would urge that you avoid doing that and exercise a lot of caution. Those compounding pharmacies, what they are doing, those medications are not evaluated by the FDA. And there's been some pretty strong warnings from the FDA when it comes to buying these medicines through online retailers or illegitimate pharmacies. So I would suggest that if you're interested in this medication or someone thinks it might be a good idea, that you go through your physician and get a prescription, and not to go through other means, even though we are aware that they're much less expensive when going through what they call compounding pharmacies or some of these boutique kind of dock-in-a-box shops where they basically will sell you whatever you want to get. I would be very careful with those types of distributors of the GLP-1s.
Thank you. So are the benefits different for younger children versus older children or adults? I mean, like basically, should I say, are the effects different for the two different age groups?
I haven't seen an age-related effect. I've I've seen it used and prescribed it down to patients who are 2 or 3 years old, and often we'll do a half dose, and they've done fine with it. But I've used it across the age span without and seen a similar effect.
Okay.
I would add, we do the same as what Dr. Kula mentioned. We may start a lower dose and then check the urine. And when we see that there's glucose in the urine, we feel like that means it's working. I would add that some of the slides we've each shared or that we look at where there's all these very interesting scientific diagrams of how it works on the metabolism. I think a lot of that work wasn't necessarily done in 2-year-olds and 3-year-olds, but that's actually the case for all the medicines that we're prescribing you for the most part. But I've found the same that I find the drug to be effective in a 5-year-old just as it is in a 25-year-old.
Okay, a couple more questions. Let's see. How would you suggest starting a conversation with the transplant team? If I'm a parent, I want to go have this conversation with Dr. Kula, who, full disclosure, is my son's nephrologist. So I might go talk to him. I know how he feels, but I'm just saying hypothetically speaking.
As a transplant cardiologist, I would say I hope that all of our families feel empowered to ask their medical teams their opinions on either medications or even specifically things they hear that are over the counter, because it's important that we as your medical teams provide you good and accurate information. So I would hope all of you feel empowered to ask, and I would just suggest we've heard about this new medication that it might help my child's heart squeeze and relax better. It might help preserve my child's kidney function. A lot of our children, unfortunately, are pre-diabetic or diabetic as a result of side effects of being on tacrolimus or prednisone. Many of our children, when we check the hemoglobin A1C, are in a pre-diabetic range. So you could even ask in regards to diabetes, even though both of us have talked about this being a heart kidney medicine. I would suggest you ask, do you think this medication might be right for my child? We'd be very interested in your thoughts and what you think if this could help my child. That's how I would phrase the question. And I would ask that you feel that I hope that you feel empowered to do so.
Thank you. Dr. Hula, if you have anything to add, that's fine. Otherwise, we'll go to the last question that we have.
Nope, totally agree with all of that.
Okay. So the last question would be, how would you say this SGLT2 inhibitor, I guess administration would work in concert with a holistic program of exercise and nutrition? I mean, obviously everybody wants their children to get exercise and eat well, but how would you describe how the interplay there?
I would say it's all additive. And with both the SGLT2 inhibitors and GLP-1 agonists, they've shown that when you tie it to positive lifestyle changes, I think exercise and diet are the most important things you can do beyond any medication. And you get more of a benefit from any medication you take if you are living a healthy lifestyle. So I think it's never like there's going to be exercise in a pill or that's going to be something you can do. But I think you just find that you'd benefit greater from it. And it might not be easy to see on any one single day or one single test. But if you think about you're taking this medicine for many, many years, that benefit could really compound and add up.
Yeah, I would add that exercise is probably the best drug or best medication anyone could prescribe. So, again, the perspective of the cardiologist, I think it's always, a good idea to, ask your cardiologist, is it, safe for my child to be active, and are there any exercise restrictions? Most of the time, especially after heart transplant, now we don't have those restrictions that we may have had before, but I would completely agree. I think exercise and diet are probably the most important things you could do to advocate for the health of yourself and your child. Oh, I think you're on mute, Joseph.
Sorry. Thank you. I think that's all the questions we have. I want to thank our presenters, Dr. Mary Chandran, who, like I said, her connection cut out during the event, and so she wasn't able to stick around, and to Dr. Spinner and Dr. Kula for spending your time with us today, as well as, doing all the original research. All three of these providers have done original research in this area, and that's why I approached them. And for this event, I saw them. I've seen them all either at conferences or doing other research-related activities. So I thought that was important that we bring the I don't want to say best and brightest, but the up and coming research. So thank you very much, everybody.
Thanks for having us.